Hey everyone, if you can hear me, let me know. Let me know how it sounds. I'm trying out some new audio equipment. Perfect. Alright. That's good. Hopefully it'll sound... You probably won't notice the difference, but hopefully I will. And if it enhances your experience, then that's great. We'll get started in just a few minutes here. But of course, if you have any questions, go ahead and put it on up in the chat, or you can put it on the sticky board. I have a few questions there already, so... And then there is the link to the sticky board in case anyone forgot where it's at. You want to check that out? Perfect. I got your class roster. Is there only one guy in the whole class? Not seen that in a little while. All right. Yeah, the first time, my first class I ever taught in PA school, I think was like back in 2015 or 16, and it was a class of 64, and there were only 2 guys in the whole class. So it's getting less and less common these days, but it's interesting nonetheless. Yes, I will address the test here in just a moment. We'll make sure get some more people in here. It's 8 hits. I didn't realize I was going to cause so much confusion, but you know, it's this class is developing. Second time we're doing it. And this is pretty different than last time since we're having live lectures and all of that. So, you know, it's okay. We'll have a few hiccups here. I think the secret to being a good PA school student is being flexible and being able to kind of roll with the punches a little bit, especially with COVID times being sort of where we're at right now. But it is 8 o'clock. I've started recording and we can go ahead and get moving here. We'll let people kind of roll out of bed and hop on as they will. So the first question here was about the test. Yes, they are going to be on Wednesdays from 8 to 9. Testing format is going to be 50 questions, 4 answer choices. The reason why we do it on Wednesdays instead of during class time is because I have a lot of material to cover and I don't want to take away from your guys' learning opportunities. And so having the test on a different time helps to facilitate that. Also, I think a lot of your exams are already on Tuesdays, and so your program director thought it would be good to sort of offload a little bit of that and have it on Wednesdays instead. So I believe the options are there to either take them in on campus or at home, depending on the situation. So if you do have labs, say like at 9 o'clock that day, I would suggest just getting to campus early, take the test, and then you're already there, so you don't have to worry about that necessarily. So I think that will work out. But let me know if you have any other questions regarding that specifically. So I did have a couple of questions on the sticky board. So looking at this, it says, I'm trying to understand slide 34, which uses an example of opioids to illustrate full agonists, partial agonists, and antagonists. Could you elaborate on what this graph is demonstrating? Why, yes, I can. So let us get to slide 34. So don't let me forget, I'm on 81. Let's get there, 34. So what is this demonstrating here? So there are full agonists, we talked about partial agonists. We talked about antagonists and kind of what their different activities would be at the receptor here. So a full agonist means that when it activates the receptor, it's getting full activity, right? So this means that if I were to give someone methadone, which is normally used to help people wean themselves off of opioids, if I were to give this to someone, you can actually use it for pain because it's a full agonist, and so it works for analgesia just like morphine does, or fentanyl, or any opioid you have out there. It also causes all that same euphoria effects that you could potentially get from morphine and things like that. There's some other reasons why we use it, and that's based on the kinetics we'll look at a little bit later on today, but that's the thing there. It's a full agonist. With a partial agonist here, the benefit is for patients who have an opioid use disorder is that it doesn't give them the full-on effects of a full agonist, meaning that it doesn't give them the full sort of euphoric sort of effects that they would normally be looking for if they were abusing opioids. But what it does do is it helps to stave off withdrawals, which we'll talk about a little bit later on. But that's where basically if you try to go cold turkey from something that a patient is addicted to, it's very difficult because they go into withdrawals because their body is so used to having those drug effects around. And, there's a psychological component too, but there's the physiologic aspects that are pretty difficult for the patient to deal with on their own. So this helps to ameliorate some of those physical effects while not giving them the full effects of a full agonist. That's why it's a partial agonist. You only get partial effect out of that. The antagonist, though, completely blocks the effect. And remember, it's not causing the opposite effect. This doesn't cause pain in a patient. But if a patient did have underlying pain issues that were being masked by the opioids, and then you block that because naloxone would sit on the receptor but not activate the receptor, you uncover all of that. So the patient may feel pain, but it's not that the naloxone is causing it, it's just taking away the analgesic effects of other opioids. And so this helps to reverse the effects of opioids. So if I have someone who had overdosed on opioids and they were to stop breathing, I could give them the antagonist naloxone and they would wake up quite rapidly because all that effect is being taken away quite quickly because of the fact that naloxone has a very high affinity for that opioid receptor. And if you recall, affinity is how tightly something binds to the receptor. And so this does bind pretty tight. So that's what this slide was trying to illustrate from that standpoint. Let's see. The other question that we had here was, can you briefly, if I can grab it. Can you briefly explain the difference between reversible antagonists and irreversible antagonists? How permanent is a permanent chemical bond with the receptor, and what signals a reversible antagonist to finally dissociate? Thank you in advance. You are welcome in advance. Hopefully my answer will be sufficient. So basically, an irreversible antagonist, that bond is going to be as permanent as long as that receptor sticks around. And so in the case of, say for instance, like an enzyme like the cyclooxygenase or COX enzyme that our NSAIDs like ibuprofen and naproxen, things like that work on, if you were to have an irreversible antagonist like aspirin come and bind to that enzyme is completely non-functional for the life of the enzyme. It's not until your body would naturally degrade that enzyme, get rid of it, and then produce a new copy of the enzyme would it start to be functional again. So in that case, it is really permanent until that enzyme is gone. In some cases, though, if it was, say, affecting a receptor on a cell surface, it would basically be in effect until the cell gets rid of that receptor, maybe internalizes it and gets rid of it, and then produces new receptors for it to act with. So, it's pretty permanent there in cases of irreversible antagonists. And so then, what signals are reversible antagonists to finally dissociate? Well, a lot of that is not necessarily a signal so much as it is just the affinity for the drug at that receptor there, right? There's a natural binding and unbinding that occurs there, and the tighter the affinity, the more likely it is to stay there for a while. Also, if I increase the concentration of drug, there's more likely a chance that the drug will bind to that receptor. So there's different things that go into that. Not really a signal per se that says, tells the drug to back off and get off the receptor there. It's naturally just as drug floating around, and how tightly it binds to the receptor is what's really going to be affecting that most. So if you have any other questions, feel free to post them up. Otherwise, I will continue on here. Do have a decent bit of content to get through, so I don't want to drag us on too much. let's see, I got about 28 people in here, so that's pretty good so far. So anyway, so we're talking about different receptor types, kind of the common ones you're going to run into, and we talked about ligand-gated ion channels, right? So those would be things where if you activate them, they then open up and allow different ions to go through, whether that be sodium or chloride or whatever the case may be. Some of them are non-specific and they kind of let whatever flow through. Some of them are very specific and only allow certain ions to go through, but they're always going along the concentration gradient. There's no energy really involved in the process. So for instance, you have a lot of sodium outside of your cells, not so much inside. If I were to open up a sodium channel, that allows sodium to flow along its concentration gradient into the cell, right? Other types include G protein coupled receptors. These are actually quite common, and they have many different varieties of G proteins here, right? And again, they all share this kind of similar shape and structure here, but they all can be quite different in terms of what this is going to bind to, and then what this segment that interacts with the inside of the cell here, right? But this is what this the actual receptor looks like itself. And so the molecule, the ligand, the drug, whatever happens to be, would come in and then bind onto this signal binding site, and then you'll find some kind of downstream effects that occurs. And again, this can be dependent on the type of tissue you're dealing with. You can have multiple different types of G proteins within the same cell surface, because again, this is the plasma membrane, this is the outside of the cell. So they're quite ubiquitous. So we have so many of them, and there's so many different drugs that actually will interact with these. So just as an example here, for mice alone, there's 1,000 G proteins just for smell, right? So we have many different types of G proteins that we're going to be running into, and we'll kind of see them as they pop up here and there. Here's an example here of a G protein coupled receptor. There's 15 different subtypes just activated by serotonin, right? So serotonin, is kind of that feel-good sort of chemical here, but we have a lot of different varieties. And I was kind of alluding to this last time we were talking about just the different functions you can see here. And so I can have drugs that affect serotonin in the body that can affect mood and treat depression. I can have some that work on nausea and vomiting. I can have some that work on all different types of things because of the variety you'll see here in the G protein coupled receptors. And again, about half all known drugs work through these types of receptors here. And again, you're going to see they all share this similar structure. They're going to have this extracellular binding site, and then they'll have an internal portion here that is going through the cell membrane that then interacts with some downstream molecules that cause whatever effect it's going to be here. Here's some examples of how this works. So here's the receptor protein, and here's the actual G protein complex that is residing within the cell. It's kind of attached to the cell membrane. But basically, you can have your cell membrane attach here, and then what's going to happen is that some energy gets involved, right? And energy currency within the cell typically is going to be through ATP. Here, that's actually going to be donating a phosphate group here to GDP, turning into guanosine triphosphate. Again, don't get too caught up on some of the minutiae here. The main point is going to be that the signal molecule binds to the G protein, and then it causes some downstream effects to occur. And so you can see how this actually happens. Once the G protein complex is activated, it can then go and have just a variety of different downstream effects. So for instance, here you can see how this can bind to something like adenylate cyclase and can actually cause the formation of things like cyclic AMP, and that can cause maybe trigger a cell to release more calcium inside of it, or to trigger mitosis to occur. All kinds of different things that can happen here. This is not a permanent process, though, because eventually you're going to find that the extra phosphate group is going to be hydrolyzed off of here, and then it goes back to an inactive state. Obviously, you don't want things, once they're activated, to be activated forever, because that's not really a well-regulated system at that point. So eventually it gets inactivated and kind of goes back to the resting state, which then allows it for it to be activated again at a later time by the same sort of signal molecule. And don't memorize this slide at all, but I want you to at least illustrate the different varieties of G proteins that you can find within the body, right? And this is just a small sampling of them. But you can see here a GS protein is involved with the actions of beta-adrenergic receptors, right? So on the heart, you can find beta-1 receptors that can be activated that cause increases in cyclic AMP, and that causes the heart to beat harder, right? Similarly, you can find them in the nose and the olfactory receptors that can allow you to smell, right? So a huge variety of them are out there, but they're all going through that same general process there, right? So, but there's other varieties too. So here's another example. Here's an enzyme linked receptor. Basically, this means it's linking to an enzyme that causes its downstream effects to occur, as opposed to the specifics of how G protein works. And so there's a lot of different varieties here. You can see some of the more common ones. The one I'm going to focus on, though, is going to be this tyrosine kinase specific receptor here. And so tyrosine kinase receptors are actually pretty neat because we're seeing that they have a huge effect in terms of like cell growth. They have a lot of effects in terms of like different hormones that can affect them. And so, for instance, a lot of tyrosine kinase receptors are involved in cell proliferation, right? Well, what disease state do we think about with cell proliferation being an issue? Well, with cancer, right? That's your cells are proliferating, where they eventually will just shut down the whole body because they take up all the resources and whatnot. And so if we can target these type of receptors here, we might have an ability to affect things like cancerous cells and prevent them from growing, or we can affect things like the immune response. So this is a sort of an emerging set of receptors that we're trying to work with in order to see what sort of powerful effects we can have in the body. So here's what this looks like. Basically, a tyrosine kinase receptor would be two kind of halves of a receptor here. You got two copies of it, and basically when you have two signal molecules come and bind to it, they then dimerize, right? Or they come together and there's two of them together, so that dimerization. And basically they will then get phosphorylated, and so you can see here all these extra phosphate groups being added on here. Remember, this is a kinase receptor. Kinase means adding phosphate groups to the enzyme. That's what happens here. And so basically it gets very energetic and then causes downstream effects to occur, right? We'll talk about some of those effects later on, but these are just the common types of receptors we're going to see here. But once this is phosphorylated, then it causes these proteins to be activated, and it can cause the cell to grow, or maybe by blocking these receptors, we prevent the cell from growing. Or like insulin receptors are tyrosine kinase receptors. Maybe this will cause more glucose channels to be shuttled up to the cell surface so you can absorb glucose from the bloodstream. All kinds of different effects can occur here. And then the final one here is going to be the intracellular receptors. This is where drugs can cross the membrane, either through passive diffusion, perhaps it's through some sort of transporter protein, something like that. But once it gets inside the cell, it can then have its effect depending on where its target is. And so as an example here, a lot of steroid receptors, whether it be say testosterone or estrogen or cortisol or all these different ones, thyroid hormone, they can then get down into, for instance, the nucleus, where they can cause changes in gene transcription and protein production, right? But they have to get inside the cell for it to actually occur in the first place. So here's some examples of different hormones that are pretty common that we'll get to talk about within the duration of this course here. But basically what they're going to do is get down into the nucleus. They're then going to bind to some sort of regulation site, and they can then change whether or not they're going to transcribe certain genes or not, or maybe affect how we're splicing different proteins. All kinds of different things can occur here once these hormones get down into the site of the nucleus. But drugs may have other intracellular sites as well. This is just saying that instead of the cell surface being at the without the receptor being at the cell surface, here the receptor is within the cell itself. Okay. So those are the most common ones you're going to run into. We'll talk a lot about ion-gated channels when we get into talking about things like neurology, when we talk about cardiology. G proteins are pretty ubiquitous. You're going to find them pretty much everywhere, but this will come up a lot with like cardiology stuff too. Tyrosine kinase receptors, this will be important when we talk about things like cell proliferation. We talk about the immune system. We'll get to those later. And then intracellular receptors like steroids, we're going to talk about probably throughout the entire course, because steroids come up so frequently in terms of how we treat disease and things like that. So those are the common ones. All right, so the next thing I want to get into is talking about dose response. What is dose response? Well, we're talking about the relationship between how much drug we're giving into the system and what sort of effects we're going to see here. Two ways we can kind of look at this. We can look at it in say like the preclinical sort of setting here. You can look at it in terms of giving drug to a specific like tissue type or cells. So if you ever done like bench research where you're actually growing cells and then exposing it to drugs and seeing what happens, right? You can do that. It's not very clinically applicable because this is you're not working with cells, you're working with people, right? Which I guess is a huge bunch of cells, but you get the point. But also you could do these studies in a group of subjects, right? So I could give a drug to 100 people at different doses and see what happens, right? So I can see whether or not they're going to have their blood pressure being lowered, or whether or not they develop a certain side effect. But what we're looking at, again, is going to be that change in concentration and the magnitude of response we're expecting to get, right? So Looking at this, and again, I'll use blood pressure probably as a common example here. So again, if I'm giving an antihypertensive or a drug that lowers blood pressure, presumably if I give more of that drug, I should see an incremental decrease in blood pressure, right? You wouldn't want to give an antihypertensive and that causes the blood pressure to raise. That would be antithetical to what you're trying to do, right? But again, we can map these relationships and actually make graphs and see what that looks like. And then the important thing too is we can then compare those to other drugs as well. So we can compare things like affinity and potency and efficacy by looking at these different curves. And so we're going to get into that. So again, when you're, say, a researcher is developing a drug and they're trying to basically show three things at first. First off, they're saying if the drug isn't there, you don't get any effect, right? So you shouldn't see any decreases in blood pressure. If I was to give someone no drug, you'd expect that to occur. Does that occur sometimes? Yeah, sure. I mean, you guys have probably heard of the placebo effect before, and that's certainly a powerful thing. That's why we do placebo-controlled trials to make sure that just because a person thinks they're taking a drug doesn't mean that they're going to get some physiologic effect. The mind is actually quite powerful in regards to that. But they want to show if there's no drug in the system, no decrease in blood pressure. The next thing is going to be if I'm adding more drug up to a certain point, you should see more incremental changes in the effect, such that if I'm adding more drug, I should see a lower blood pressure, okay? And then the final thing here is if I'm taking away the drug, it should go back to baseline, right? So the blood pressure should go back to the pre-medication level if I were to then withdraw that drug, okay? Those are the three things you have to show to make sure that your drug actually is doing what it's supposed to be doing and it actually works, right? And so how you would actually look at that relationship here is between the response of the drug, meaning this would be the change in blood pressure. This could also be pain scale. This could be really anything you want it to be on the y-axis here. And then you have the concentration on the x-axis. And so what you come up with are these sort of S-shaped curves here, where you're going to see that initially when you have no drug around, you're getting no response. You'll have sort of this steep curve in the middle here. And again, the steepness or the shallowness of this curve will mean something. We'll talk about that later. But also you'll notice it will plateau at a certain point. Now, what's going on here? Why does this plateau? Well, this is when you saturate all of those receptors. If there's nowhere else for the drug to bind to because they are all already occupied, that means that this is now fully saturated. You can't get any more effect here. So there's always going to be a plateau effect for the most part. So again, you can refer back to this. And when I mentioned the y-axis, the effect, it can really be anything. So it can be enzyme activity. It could be secretion of a hormone. It can be anything. So we'll talk about different examples of that as we go forward. So some definitions when we're looking at dose response curves. First off is going to be what we call the ED50 or the median effective dose here, right? So this is basically the dose where 50% of the population is giving or getting the effect that you're looking for, right? So this is the midway point here. This will be important because we can then compare ED50s between different drugs together and actually be able to ascertain some comparative results between drugs. And so we'll look at that in just a little bit. But basically the midway point in this curve here between the 0 point and the maximum point should be the ED50. Okay, so if I were to say give patients, I have 100 patients, I'm giving them a new sedative drug. What's the point at which 50% of those patients are asleep? Right? That would be the ED50 for that drug. Now, you don't dose at the ED50 because of the fact that if I were to give a drug to a patient and say, well, there's a 50% chance it's going to work, they're not going to think it's a very good drug. You want it to be a little better than 50-50. But in terms of theoretical terms, this is good because it helps us to compare different drugs together. So we'll talk more about that in a moment. Now, as I mentioned, 4 major parameters of the curve here. You're going to have that baseline response at the bottom where there's no drug, so you should get no effect. You're going to have the maximum response, or the Emax is another way that will be referred to occasionally. Again, that's when you have all the receptors being saturated, or you're having 100% of the population you're treating getting the effect. The slope, again, is going to be important because this tells me how big of a change I'm going to see in effect based on changes in the dose I'm giving, right? So if this is a very steep curve, this would mean that very small changes will cause very big changes in the patient. Small changes in dose will cause big changes in the patients. This is very shallow. This would mean that even large changes in dose probably wouldn't cause a really big effect in terms of how many patients are getting a response or what kind of effect I'm seeing there, okay? But the ED50 is really important. This is, again, going to help us to be able to compare different drugs to one another, okay? And this also helps us to determine potency, which, if you recall, potency is how much drug I'm needing in order to get an effect. So whether that's going to be milligrams of a drug, micrograms, or grams of a drug, that goes back to the potency. There's two main varieties here we're going to talk about. There's the graded dose response curves and then the quantal response. Graded response curves are going to be good if we were to, say, give a drug to an individual patient or, say, like an individual tissue or something like that to see what sort of effects we're going to get, right? So if I'm looking at, say, blood pressure changes in an individual, that's going to be a more graded dose response curve. We're going to talk about these first, and then we'll get into all or none sort of responses, or these quantal dose responses. And this is going to get into examples where you're giving drug to a population and saying whether or not they got the intended effect, right? So if I'm saying giving a sedative drug to patients and saying, did they fall asleep or not? Or did they achieve analgesia or not? Or whatever the case may be. So we'll look at that in just a few moments here. So with the graded dose response curves, what it's sort of illustrating for us is saying, okay, well, based on changes here between the drug concentration and how many receptors I have available, how much of this complex am I getting here to cause the effect? And so presumably if I increase the concentration of the drug, I should be getting more of this complex forming and thus more effect out of that drug. So this is basically illustrating that relationship. And again, once the receptors are saturated, it doesn't matter if I give any more drug or not. I'm not going to get any more effect out of that because they're all occupied at that time. Okay. And so what we're going to see here is that this should be a continuous and gradual sort of response with the graded effects, as opposed to quantal responses where it's really all or nothing kind of thing. It's a yes-no sort of binomial sort of effect that we're going to see. But we'll look at the graded dose response curves first. And this is done a little bit more in sort of the preclinical sort of setting, but it's still good to illustrate some of the concepts we're going to be talking about. And again, looking at the relationship between the dose, the receptor occupancy, and then that magnitude of effect I'm going to be getting there. Okay, this will make more sense when I'm showing you some graphs here, what that looks like. And again, what you're going to find is that maximum response is when all the receptors are occupied. Half max response, or the ED50, should be when 50% of the receptors are occupied. All right, so some things this can tell us. So one, it can tell us about the potency of the drug itself, right? So if I'm looking at effect on the y-axis here, the dose here on the x-axis, the potency is going to be basically how far to the left or right that ED50 is. Okay, so again, smaller doses are going to be on the left side of the x-axis here. So the closer the ED50 is to this left side, the smaller the dose needed to get the effect I'm looking for, versus the farther to the right it is, the more drug I'm going to need to get that 50% effect. So this tells us the potency, because if it's closer to the left, especially if I'm comparing two drugs together, the closer to the left it is, the less drug I need to get that effect, the more potent it is. So further to the left, more potent. Further to the right, less potent. Okay. We can also look at efficacy as well. So where that E max is, or that maximal effect is, how high this goes tells us how effective that drug is going to be. Okay, so in here you may look at like contraction of a muscle or something like that. The E max, the higher this is, the more effective a drug's going to be. Okay. So, and again, what that's going to help us to do is be able to compare those drugs together to see which one's more potent, and then also which one's more efficacious. And you as clinicians are probably really going to care about the efficacy more so than the potency, but know that why different drugs are dosed differently has a lot to do with their potency, right? So if I were to look at three different drugs here, A, B, and C, you're going to see that, again, the further the ED50 is to the left, the more potent the drug is, the less I'm going to need to administer to get the given effect. The less potent it is, the further off the ED50 is going to be to the right, the more drug I'm going to need. So for instance, drug A here might be micrograms of drug I'm giving, B might be milligrams, and C might be grams, for instance. That's a pretty extreme example, but that illustrates the point. In terms of efficacy, all of these drugs could be equally efficacious as long as I'm dosing it correctly. So I would only have to give, say, some micrograms of drug A to get maximum effect, versus C, I might have to give grams, but ultimately they can all be equally efficacious. So which one you decide to give your patient really doesn't matter, because you can get the same effect. But, when you're looking up your drug references, your Tarascons or your Lexicomps or wherever you go for your drug references, Hippocrates, that's why those drugs may be dosed so differently, right? That's kind of why that is, because of the potency of the drugs there. So if I were to compare four different drugs together in terms of which one is most or least potent here, again, you're comparing the ED50s of these four drugs. You would be able to say that drug A is the most potent, followed by B, followed by C, and followed by D. Now again, not all of these drugs are equally efficacious, but again, it helps me to determine how much drug I need to give to reach that ED50. Okay, we'll talk about efficacy here in just a moment. But you should be able to look at a curve like this and be able to determine, okay, which one is going to be most potent based off of this. So, but again, I mentioned efficacy is what we care about because we want our patients to have effects, right? We want them to lower that blood pressure or to feel analgesia or whatever the case may be. You're going to find here that agonists are going to have a positive efficacy, right? So they're going to cause the actual curve to go up here. But again, antagonists should have zero or no efficacy. So if I were to look at, say, for instance, analgesia or pain scale on the y-axis here, and I were to give an antagonist like naloxone, as we were talking about in that previous slide at the beginning of class, that should be a flat curve. I can give a patient grams and grams and just a ton of naloxone, it would never cause analgesia because it just doesn't, it'll bind to that receptor, but it never activates it. Agonists, though, if I were to give fentanyl or morphine or heroin or whatever the case may be, should cause the curve to go up because that does have agonist activity and is going to cause the cells to be, or the receptors to be activated and cause a given effect. So we're going to see that the higher the curve goes, the more efficacious the drug is going to be. Okay, so here we can see that C and A would be equally efficacious, whereas B and D would be equally efficacious to one another, right? So you're saying, well, which drug should you give? Well, A or C would be fine choices if you need that much analgesia, right? So I would just have to dose it differently in order to account for their differences in potency, okay? So again, looking at this, as I mentioned, the top of that curve, there's the Emax. That's how you can tell overall what's the maximum efficacy you'd be looking for. Now, again, you're not necessarily dosing an Emax for every single drug you have out there, right? So imagine you have two patients sitting in your ER lobby. One has a broken femur with the bone sticking out of their leg, and the other one stubbed their toe. You're like, why'd you come to the ER? But they came to the ER anyway, so you got to take care of them, right? Obviously, that person who stubbed their toe doesn't need the same kind of efficacy as a person with an open fracture. So you would give them different agents, right? I don't need to give the person that stubbed their toe morphine. They might be asking for it, but I'm not going to give it to them. Versus the person who has that femur sticking out of their leg, if you gave them something like Tylenol, they would be quite angry with you because that's not going to touch it, right? So context is important too in terms of how much efficacy you're really looking for, right? Now, if I were to compare the efficacy of these four drugs again, we talked about a few minutes ago that A would be most potent, right? A is the furthest to the left here in terms of its ED50. But if you were to look at the order of efficacy, A and C are going to be equally efficacious. B would be a little less than that, and then D would be the least efficacious out of the bunch, okay? That might be okay, right? D might be just is all the efficacy you need, but it's not going to be the same as like A or C. And you can kind of equate this to things that might be partial agonists, for instance. So A and C might be full agonists, whereas B and D could be partial agonists of varying degrees, as you can see here. So again, affinity is an important term here, and then intrinsic activity. Affinity, again, is how tightly it's binding to that receptor, and then intrinsic activity is how well it's activating it. So if it's a full agonist or if it's a partial agonist, how much activity does it then activate? Typically, you're going to find that higher affinity causes a drug to be more potent because it binds more tightly to that receptor, and you're more likely to get that complex to occur there. Whereas intrinsic activity is going to be really more important in terms of how much efficacy you're actually going to be getting out of that, okay? So those are kind of the main takeaways from that. And again, clinically, you're really going to be more so concerned with the clinical efficacy of a drug rather than the affinity. But these things can come up in terms of like why drugs are dosed differently than one another, why different indications might have different dosing, for instance. All that can go back to one, the affinity and the intrinsic activity of the drug itself. And recall that antagonists should have no affinity whatsoever. So they bind to the receptor. They can have really good affinity for the receptor, but they may have or should have, as an antagonist, no intrinsic activity. So those are kind of the differences there. So flipping over and then looking at what we call a quantal dose response curve. So before we were looking at sort of it's like a change in blood pressure or a change in pain scale, say in an individual, or say we were working on like a cell culture or something like that. Quantal dose response curves are more clinically relevant because this is where you're looking at a population. So say I'm giving it to 100 patients, or I'm giving a drug to 50 people, whatever the case may be. I'm looking at to see, do they experience the effect I'm looking for, yes or no? So it could be, do they fall asleep or not? Could be, do they have a 10% drop in blood pressure or not? And what these quantile dose response curves help us to determine is what percentage of people achieve that given outcome, right? And the ED50 here is going to be basically when 50% of the patients achieve that outcome. So again, using sedation as a term here, sleep is considered sort of an all or none phenomenon. So either asleep or you're not asleep, right? And again, if I were to dose a sedative drug at the ED50, this would be the point at which 50% of patients are going to be asleep. Now, again, I'm not going to send someone to surgery with a 50% chance they're going to be asleep for it. That would obviously be pretty inappropriate, but you get the point. This helps us to compare drugs together and helps us to determine sort of how we need to dose it and what's the maximum efficacy you're going to get, right? So again, if I were to give someone, say there's a drug propofol. Most of you probably know propofol from Michael Jackson. That was a drug that ultimately led to his untimely demise. That's a very heavy sedative. That can knock someone out for surgery, no problem. Versus if I were to give you something like Benadryl, diphenhydramine, it's an over-the-counter antihistamine. That might make you a little sleepy, but it's not going to knock you out for surgery, right? So again, the efficacy can be wildly different between these different drugs here, and along with the affinity for the different receptors that they're going for. Now again, as I mentioned, ED50 in these quantile dose response curves is when 50% of the people are asleep or awake, as the case may be, or whatever effect I'm looking for. And then we can also now start to talk about toxicities too, right? Because again, when you're deciding when to give a drug or what drug to give, you're not just looking at how efficacious the drug is. You also want to know what kind of side effects can you expect to see. Or could this drug kill the patient, right? Anything can be poisonous. It just depends on the dose at which you're giving it, right? So we talked about the ED50 quite a bit, but now we have things like the TD50, which is the point at which 50% of patients are manifesting a toxic effect. And then we have the LD50, which is when you're dosing a drug at a point which is going to kill 50% of your subjects. Now, again, you should be dosing nowhere near the LD50, but we can see this can change wildly depending on the drug that we're looking at. So now we're not necessarily just looking at the efficacy of the drug. Now we want to know about the safety of the drug as well. And so by looking at things like the ED50, TD50, and the LD50, this can give us a more clear picture. You can have the most efficacious drug in the world, but if it's very likely it can cause serious harm or kill somebody, it's not a very good drug, now is it? All right, so looking at this, we can see how these curves can have some degree of overlap or not, depending, and again, how wide of a difference there are between these curves can tell us a lot about the safety of a drug. You're going to see here that every drug has side effects, and again, when I say toxic effect, what does that really mean? It can be anything, right? So, for instance, if I'm giving someone Benadryl as an antihistamine, they use it for allergies, the therapeutic effect could be to decrease itching, right? The toxic effect could be causing lethargy or sleepiness in the patient, right? So comparing those two together can give me an idea of how much overlap there is between the two. In that case, there's a lot of overlap because many patients get sedated from taking Benadryl at therapeutic doses that would treat their allergies. On the other hand, though, I could switch it over and say someone's having insomnia and they're taking Benadryl to go to sleep. Now that it's switched over, and now this is the therapeutic effect, and then the toxic effect could be something else, right? Lethal effect is always lethal effect. It's, again, patient's either dead or alive. So an important concept here we're going to talk about pretty extensively is what we call the therapeutic index. And so this is going to be the ratio between the toxic effect of a drug or the lethal effect and the effective dose 50, right? So the ED50. So there's always going to be a ratio where the ED50 is in your denominator and the TD50 or LD50 is going to be in the numerator. And again, you can define the TD50 to be whatever effect you're looking for. The LD50 is always going to be death. And so depending on the amount of overlap you have here, can give you an idea of how wide of a therapeutic index you have. If the ratio is quite large, this means that these curves are nowhere near one another. Versus if it's a narrow therapeutic index, it means there's a lot of overlap between the two there, okay? And again, this is very helpful for determining how much safety there is. Now again, when you're dosing a drug, you're not dosing it at the ED50 here, right? Because that's only 50% of your patients getting the given response. You're probably going to be dosing somewhere closer to up here, right? Where you should be having maybe 95 to 100% of your patients having a response. But again, when you're dosing higher up here, more likely you are to have some overlap with one of these other curves, either TD50 or LD50, right? And so here you're looking at an example of morphine. We're looking at the analgesic effect and then the respiratory depressive effects, right? So whether or not they have the impulse to breathe or not is a pretty serious toxic effect you can see with morphine. So looking at this, you can see that by the time I'm dosing to where 100% of patients are getting the analgesia I'm looking for, you can notice here that there's a low chance that they would have respiratory depressant effects, right? But what happens if I were to push this further and give more drug to that patient there to really make sure they're getting the analgesia they're looking for? You're going to see that the likelihood of them developing respiratory depression has now gone up quite a bit, right? So again, your dosing is very important because not only will it cause analgesia, which you're looking for, but also you have to think about the toxic effects you could get from giving the drug to the patients here. So again, you want a wider separation here between these curves to indicate more safety, right? So again, if this ratio, and again, the ratio with the numerator being the TD50 or LD50, ED50 being the denominator, the wider and the larger that ratio is, the less overlap there is here and the safer the drug generally is. And again, looking at the comparison here, this would be an example of something that would have a wide therapeutic index, because even if I'm at the point where I'm dosing to where 100% of patients are getting the response I'm looking for, there's no overlap here, right? So this would be considered something to where you're getting a wide therapeutic index. This would be relatively safe here, right? And again, you can see the calculation, how you do that there. And again, the curves can also be different too, right? The steeper the curve here, the more rapidly you're going to have more patients develop that as you start to get up to those sort of concentrations there, right? So steep and shallowness of the curves can also be important, which I'm not going to focus too much on here. But again, the ratio is really important here. So that therapeutic index is just a ratio between those two, which I've already kind of talked about. So as I mentioned, a high therapeutic index is preferable to a low one, right? Because you want to have less overlap between those two curves there to show that there's a wide range of safety. So even if you were to give a twofold overdose, hopefully you're nowhere even near the TD50 or the LD50 for that given drug, right? So for instance, there's a sedative agent called diazepam, or Valium is the brand name, used for anxiety or muscle relaxation or sleep, as the case may be. Its therapeutic index could be 100, right? Which is relatively forgiving. I can give several fold overdose and I'm probably not going to kill that patient because the therapeutic index is relatively wide, as opposed to something like an antiarrhythmic, digoxin, which is a heart medication used to treat things like atrial fibrillation, congestive heart failure. Its ratio may be like 2 to 3 times. So that means even small changes in dose can get me closer to the TD or LD50 and be more likely to cause harm to the patient, right? So you're saying, well, why would I ever use digoxin? Well, sometimes it's the best drug for that patient, right? Maybe that's the drug that's going to have the most efficacy, and you take the good with the bad. A lot of what we're going to talk about when we get into specific topics and disease states is balancing out the difference between the toxicity of the drug and the efficacy to kind of figure out what's going to be best for your patient. What are the trade-offs you're going to have to be looking at? And so when we're doing, we have drugs that have a narrow therapeutic index, so something like digoxin has a small window in which you need to dose it in before causing toxicity. We call this a narrow therapeutic index drug. And so when you hear about patients getting drug levels being done, it's typically done to drugs that have a narrow therapeutic index. So sometimes drugs will have a very narrow window in which you're going to cause efficacy, but going much higher than that can cause toxicity. And so we do blood levels to make sure that they're in that therapeutic range. And so that's called therapeutic drug monitoring. We'll talk more about that as we get into specific topics and certain drugs. Here's some examples of drugs that have a narrow therapeutic index. Again, don't memorize this list. I'm just giving you examples of drugs that you may see that have a narrow window in which they would be useful to treat the patient's disease state, but going above that can lead to significant toxicity and harm. So for instance, like phenytoin is a drug we use to treat seizures. If I'm dosing it too low and they're below this window here, 10 to 20 mics per ml, they may develop seizures. If I'm dosing it more aggressively and I get above 20 mics per ml, I'm more likely to cause toxicity associated with the drug. We'll talk about what those toxicities are. So what you're really looking for is that Goldilocks sort of window there where it's just right. It's not too much, not too little. It's just right. And so that's where our therapeutic drug monitoring comes into play. Okay. And again, looking at another pictorial example, here's two different drugs. One is warfarin, which is a blood thinner. So as you might imagine, we use it to prevent clots, but giving too much of it can cause bleeding. This has a relatively narrow therapeutic index, right? So when I'm dosing it to get 100% of patients to have a response, I'm going to be having some degree of bleeding associated with that, right? It's just natural that that would occur. Again, taking the good with the bad. Versus something like penicillin, That's a very wide window here. So if I were to give someone a double dose of warfarin, that could put them up in the range of having significant bleeding, no problem. Versus if I give a double dose of penicillin to a patient on accident, they're probably not going to have a whole lot of issues there because the therapeutic index is so wide. So generally speaking, a larger therapeutic index, the better or the safer the drug is, right? So overall, by using these two curves together, it can give us quite a good idea of the overall efficacy of a drug, how much drug we need to get a given effect, and then overall safety as well. So what do you care about? You care about efficacy and safety of the drugs there. But know that when we're dosing drugs differently, you can know that this has a lot to do with why that is. Why a drug is dosed in micrograms, milligrams, grams, whatever the case may be. That's all to do with some of this information. Okay. So another thing I want to talk about is the concept of drug safety. So you can have patients that have a lot of variety in drug responses. Like, why do patients act differently to certain types of drugs there? Now, let's see. Uracillus, which I'm sorry if I said that incorrectly. On slide 122, the two ratios listed that equal TI have different numerators. Why is that? Is there any difference in they both equal the TI? Let me see here. So 122. All right, so looking at that, remember that the therapeutic index can either be the toxic dose 50 in the numerator, or it could be the lethal dose 50. It depends on how you're defining it, okay? So depends on the study they're doing or whatever the case may be, but you can pick that. And again, which toxic effect you're looking for is something you should be defining as well, right? So for something like Benadryl, it could be sedation, or it could be or dry mouth, or it could be urinary retention. You define what that is, but you can basically define that and get the therapeutic index for each one of those effects there. And then Jillian's asking, will be calculating therapeutic index or just interpreting it? You should be able to interpret it, right? So you should be able to look at a TD50 and an LD50, and you should be able to, or in the ED50, I should say, and you should be able to compare those two and see, okay, well, which of these drugs would be safest, for instance, or which one of these drugs is most dangerous by looking at that. And again, the bigger that difference there, the bigger the ratio, the safer the drug is going to be, okay? All right. So thank you for asking questions. I appreciate that. It makes it a little more interesting for me, and hopefully other people had the same question as you did. So anyway, so why do people have variations in response to a drug? You can give the same dose of drug at two different times to get wildly different effects. Or I can give two similar patients the same dose of the drug and, again, get a lot of variety in response there. So why does that occur? Well, I want to talk about the different types of response variations that can happen with your patients here. So here's some examples: idiosyncratic responses. We'll talk about tolerance and tachyphylaxis, and then hyper and hyporeactive responses there. So idiosyncratic responses, what does that mean? Basically, this is going to be a rare or an abnormal response to a drug that's not really explained like by the pharmacology action of a drug. Like if I'm giving a patient an opioid and it causes respiratory depression, well, I know that that is natural to occur because that's part of the pharmacologic actions of the drug. This is something different, though. This is something that can't really be explained by the pharmacology of the drug. And it's not an allergic response, right? And again, it's difficult to predict because it's not going to happen in regularity. I can give a patient a drug, they have this sort of one-off sort of side effect that you wouldn't expect to occur, and then you can give it to the same drug to another patient and they wouldn't have any issues with it whatsoever. Right? That's why I call it idiosyncratic, because it's difficult to predict who's going to have that response. And so as an example here, you can have these responses occur by a variety of reasons, but frequently happens to be due to genetic predisposition. So as an example, some patients are going to have a deficiency in an enzyme called G6PD, right? G6PD is an enzyme that's responsible for a lot of, oxidative and reductive reactions in the body. But it's really important because it helps to keep your blood cells intact. And so some patients have a natural deficiency of that enzyme, and it's kind of difficult to predict who's going to have that deficiency unless you do a blood test. And it's rare enough that you don't test everyone for it before you give them certain drugs. But you can have a patient, say, have a patient who's going to go to a place where malaria is endemic, right? They're going for a mission trip or something like that. Giving them the drug Primaquine, which is used to treat malaria, can actually cause hemolysis and really severe hemolytic anemia in patients if they have the G6PD deficiency. And again, very few people are going to have this reaction, but when it occurs, it's pretty severe, and you should be aware of it happening, so that way you can respond to it as appropriate. But this is just one example of an idiosyncratic response you can have with a drug. Now, more often than not, you're going to run into what we call hypo or hyper reactive responses, where patients should be getting they're getting a normal therapeutic dose of a drug, but they either have no effect or little effect, or they have way too much effect that can occur there. So, excuse me. As an example, with the drug diphenhydramine or Benadryl, some patients, when you give them Benadryl, even at relatively low doses, they get really lethargic. They get really sleepy off of that, It's like a therapeutic dose of Benadryl might be 50 milligrams, right? I can give some patients 25 milligrams. They're adult size, and they are knocked out for like the rest of the day, right? Or they're not good to drive or things like that. That's a hyperactive response because they're getting much more effect than I would have expected based on that therapeutic dose. On the other hand, though, some patients have the opposite response. They have severe excitation. They're basically bouncing off the walls. And so it's a kind of a hyporeactive response when giving something like Benadryl, right? So again, you can kind of go either way depending on the patient, because everyone's a little different in these cases here. Or in some cases, again, it could go back to their genetic predisposition. So with an example of an opioid pain medication, there's one called codeine. If you ever heard of like Tylenol number 3, that includes the drug codeine. It actually works for pain by being converted in the body over to morphine. And it's done through an enzyme called CYP2D6, which we'll talk more about later on. But basically, some patients have a lot of this enzyme, and some patients have very little of this enzyme. So if they have too little of the enzyme, they don't convert very much codeine over to morphine, and the drug's not all that effective for their pain. Versus some patients who have a lot of the drug around, or the enzyme around, they convert a ton of that codeine over, and that drug works really well for them, or maybe too well, and can actually cause some side effects there. So all examples of hypo or hyperactive responses. Now, another thing that happens frequently is to patients who are on drugs for, say, a prolonged period of time. And so they can develop what we call tolerance, where they take the same dose of drug over the course of, say, weeks to months to years, and you start to see the efficacy of the drug start to dip down. And you're like, well, why is it not working as well as it used to? And that's because of the body having its own homeostatic sort of responses, right? And so the body's doing a sort of a protective sort of mechanism. And so what you do to overcome that is by giving more of the drug over time. And so you can have patients, you can see some patients who are in hospice care that are, 90 pounds sopping wet, elderly patient who is on doses of opioids that would kill a horse practically, because they've developed tolerance over a long period of time. They've had to gradually increase that dose over the course of years in some cases there. Similarly to stimulants like caffeine, right? You'll notice this being in PA school is that your normal consumption of caffeine may not be cutting it anymore because of things like tolerance to your normal amount of coffee you'd get, or whatever the case may be. So how do you overcome that when you got a big test coming up the next day and you got to study for it? You got to up your dose, right? You got to increase the dose in order to overcome that tolerance to get those effects back. So that's a key point there, is that by increasing the dose, you can get back to having the efficacy that you're used to seeing there. There is a concept, though, where even increasing the dose doesn't overcome the tolerance. And that's called tachyphylaxis. This is something to where patients who, even if you keep increasing the dose of the drug over and over again, you're going to find they don't really get any more efficacy out of that drug. And the reason for that is due to either homeostatic responses by the body, or sometimes you reduce the amount of neurotransmitter that you're working with, or the enzymes are exhausted, or whatever the case may be. Or even if I give more of the drug, you don't get to see any more effect out of it, right? So a really good example of this is going to be nitroglycerin for chest pain. I'm sure most of you are familiar. If you're having chest pain, pop a nitroglycerin under your tongue. That hopefully is going to cause the chest pain to go away. But for some patients, if they're taking nitroglycerin around the clock, they can pop that nitroglycerin when they have their chest pain, and it doesn't work, because they've depleted those natural cofactors and things like that are necessary for it to cause the chest pain to go away. We'll talk about that mechanism later on. And that's why if you ever look at the dosing for nitroglycerin long-acting products, they say wear it for 12 hours on and then 12 hours off. The reason for that is that 12-hour off period allows the body to sort of reset itself to get back down to baseline. So that way the next time you give nitroglycerin, it will be effective again, right? So tachyphylaxis is a temporary effect, but I have to withdraw the drug in order to give the body a chance to reset, and then I should be able to get that effect back again. Okay? So, and again, why do we get those variations in response? Well, it can be due to a number of different things here, right? So these are the four we'll talk about in more detail here. But looking at alteration in the drug concentration, that reaches the receptor, right? So what could be happening here? Well, it could be due to some pharmacokinetic factors that we're going to get into in the next lecture here. But basically, you can have things like upregulation of enzymes to metabolize the drug. So for instance, if I'm increasing the amount of enzymes available, I'm going to chew through that drug more quickly, and thus the levels are going to go down. So it seems like the drug is being less effective, but it's really because my body's clearing it from the body more quickly, right? Other factors can go into this too, right? So it could be genetics, could be age, could be weight, could be a lot of different things that could be affecting this. Or could even be the body's ability to get rid of drugs because they see the drugs as poisonous, right? So for instance, with cancerous cells, they can actually develop resistance to some of our chemotherapy because they recognize it as a poison, so they develop resistance to that by being able to expel the drug out of the cell. That's another way that you can basically prevent enough drug from getting to the site of action, and then it's going to be less effective. If it doesn't get to the receptor that it works at, it's not going to be very effective. Other things can happen too, about like the variation in endogenous ligands. So for instance, we have a drug called propranolol, which is a beta blocker, right? So what does it do? It blocks beta receptors. For instance, we have beta 1 receptors on the heart that it can block to slow down heart rate. Well, it mainly is going to be doing this when you have a lot of catecholamines floating around like epinephrine that normally bind to and increase heart rate, right? So epinephrine is part of your fight or flight response, your stress response, causes your heart rate to go up. And so if I have high levels of epinephrine around and I give someone a beta blocker, it should be able to block that epinephrine and lower down the heart rate. But if there's not a whole lot of epinephrine around in the first place, then it's not really going to cause much of a difference. Because even if I'm blocking those receptors, if they weren't going to be activated anyway, maybe I don't see any change in effect. So this is why you can give something like propranolol for stage fright, or say if you're giving a lecture or having a performance of some kind, if you're at normal baseline levels like you might be at right now, giving a beta blocker might not cause a lot of big changes in your heart rate or blood pressure necessarily. But if you're in that really fight or flight response, your heart rate's going 200 beats a minute. Hopefully it's not going 200 beats a minute, but it feels that way because of all that epinephrine floating around. Then propranolol can block that and then cause the heart rate to come down. You feel more calm and you can give your speech, right? So sometimes that can be a factor there. And then a big thing that happens too is going to be due to the number and function of receptors. So are we having up or down regulation of the number of receptors available, right, to interact with the drug as the case may be? So in some cases here, you can find that the body can be sensitized to certain substances due to the fact of things like hormones. So for instance, you know that if you have hyperthyroidism, so you have too much thyroid activity, you can see things like increase in heart rate and blood pressure, and you're sweating more because it can do things like upregulate the number of beta receptors available in the heart, for instance, right? So more receptors available to interact with things like epinephrine, the more likely that's going to occur, and then heart rate goes up, right? And so then you can find that with tolerance and tachyphylaxis, a lot of that has to do with reducing the number of receptors available. So sometimes by overstimulating the cells by activating those receptors, they say, well, there's too much activation going on here. Let's reduce the number of receptors available. Thus, you desensitize the patient to those drugs, and it needs more drug in order to get the effect you're looking for. I'll give you some more clinical examples as we go forward. But this term of desensitization is that thing where you're kind of constantly sort of activating a receptor to the point where the cell is saying, hey, we gotta reverse this effect here or try to mitigate it to some degree. And so that can change either the sensitivity of the individual receptor, or it may cause the cell to either just maybe not produce as many receptors or shuttle them up to the cell surface there. And this is a defense mechanism, right? Because in some cases, overactivation can actually cause the cell to die. It's called excitotoxicity. And so by preventing excessive stimulation, you prevent that damage from happening there. And so again, when you have patients, they're getting the same drug over and over again, you can find that diminished effect in some cases. And so that's, again, part of that tachyphylaxis. And by withdrawing the drug, allowing the body and the cells to get back to baseline, then you can give the drug again and should see that same effect. So, and here's a pictorial example of how this would occur, to where if I were to say give the same dose of a drug 2 times within a relatively short period of time, you can notice here the efficacy is going to go down, versus if I wait an hour or so and then give it again, you're going to see it goes back down to baseline, right? The baseline response, I should say. So that's just an example of tachyphylaxis and that desensitization that comes along with that. So in some cases, though, you could also get what we call like a rebound phenomenon. So this is a case here where, actually, it makes more sense if I give you the pictorial example, but you can refer back to this to get an idea. So let's say, for instance, this is the heart. This is a very colorful heart. Hopefully yours is not green, but let's say here I got some beta receptors in the cell surface here and that can interact with things like epinephrine. The triangles here are epinephrine. This is the normal number of receptors that are available. Well, sometimes what can happen is if I'm giving something like a beta blocker, or this is the baseline state where the heart rate, blood pressure is a little high maybe, but this is a pretty normal state. What would happen if I give a beta blocker to antagonize these receptors here? But again, it doesn't activate it, just sits there and blocks it. Well, maybe I reduce the heart rate and the blood pressure down to acceptable levels here. What's interesting is that by constantly blocking these receptors, the cell's saying, well, I'm not getting enough activation here. Let me get more receptors available. Let me try to increase those number of receptors and upregulate them at the cell surface. So basically, you're going to find that what happens now is if you were to abruptly withdraw that drug, now all of a sudden you have way more receptors available to interact with things like epinephrine. You can get way more activity than what you would normally see at baseline, right? So it's called a rebound phenomenon. And this is going to actually lead to things like heart attacks for patients that run out of their medications and things like that. You may see cases like that. I saw some news stories recently where, due to post office delays, patients aren't getting their heart medications, right? So that could be potentially deadly due to some of these rebound phenomenons potentially. So we'll cover examples like that when we go forward. And then some other things too, you can find that not only can the receptors change, but also downstream effects further in the cell can also change as well. That can maybe diminish the effect of a drug potentially, right? So for instance here, if I'm giving a beta blocker to lower blood pressure, and I'm using that to lower the blood pressure to an acceptable rate, your body has other mechanisms in order to overcome that, right? So it's not just your heart that is going to be affecting blood pressure, but also your kidneys, right? So if I give a drug to lower blood pressure and the body says, whoa, we need more pressure here, we need to increase that, your kidneys can also have some effect in order to raise that up. And so this is all part of maintaining homeostasis. We'll look at some ways that we can overcome that. Potentially, sometimes it has to do with the dose of the drug we're giving. Sometimes we can give more drug. Sometimes we can give additional drugs in order to overcome some of these changes here. So one last thing I want to talk about here is this idea of clinical selectivity. So how do we define whether we're getting the beneficial or the detrimental effects of these drugs here? And a lot of it has to do with how selective our drugs are. Sometimes this has to do with the targets that it's looking for. Sometimes it has to do with the dose that we're giving. So for examples, in terms of antibiotics, right? Well, antibiotics are looking for bacterial targets to kill. So they don't really affect our human cells as much. So they're pretty selective for affecting just bacterial cells and not hurting us, right? So fewer side effects. Versus a lot of our chemotherapeutic drugs, they can't tell the difference between a cancerous cell and a non-cancerous cell. So because of that, they are very toxic and they affect kind of all cells equally. So that is not very selective. So ideally, we'd like to be able to isolate out and just get the as selective a drug as possible, but that may not always be available there. And so when we're looking at drugs, that's why we have to define all those different TD50s and all of that to get different therapeutic indices to tell us, how effective is this drug going to be, but also how safe is it going to be to try to delineate between those toxic effects and the therapeutic effects. So in some cases, you're going to find that efficacy and toxicity are going to be through the same mechanism. I mentioned this earlier with the drug Coumadin or warfarin. It's a blood thinner, right? It prevents clots from occurring by making the blood less likely to cause coagulation to occur. And so here you can imagine that if I were to give more of that drug, well, guess what? They're more likely to bleed in those cases there. So that's why you can see the major toxicities of warfarin are going to be GI bleeds and strokes and things like that. Or like the drug insulin. If I'm giving too much insulin, you're going to see that normal doses will lower blood glucose, but then I can give too much, and that causes hypoglycemia to occur. In these cases here, you have to weigh the benefit versus the risk to make sure you're giving enough to get to the therapeutic effect, but not so much you're going to cause toxicity there. So that's kind of you have to thread the needle a little bit in terms of that. But in some cases, though, you can find that the toxic effects of a drug are mediated through entirely different tissues or entirely different effector pathways. So as an example here, I can give someone a steroid, a corticosteroid like prednisone, say for an asthma exacerbation, and normally that treats inflammation. That normally helps out with the asthma exacerbation. But also you're going to get a lot of other effects as well because corticosteroids just don't work in the lungs. They work everywhere. So that means they can do things like increase glucose. It means it's going to be bad for your diabetic patients. Or if they have CHF, of fluid retention. And so some ways to get around that are by doing things like using the lowest effective dose, or maybe using more direct routes. So if it's an asthma exacerbation, using an inhaled form might be able to help prevent some of those other ancillary effects throughout the rest of the body. Or if I can use something with an alternative mechanism of action, that may be useful if it's available, right? And so looking at this here, you can see that sometimes our drugs can be selected to the point of being able to isolate out specific subsets of a given receptor, whether it's an enzyme or a cell surface receptor or something like that. And so that helps us to be more selective as well. So as an example here, H1 versus H2 blockers, H being histamine in this case here. H1 blockers are good for allergies. H2 blockers are good to help decrease stomach acid production and treat GERD. And so by isolating out these effects here, I can make sure that I don't give someone who is having GERD symptoms and making them extra sleepy because of these extra H1 effects that I don't really need, right? So we can be selective in terms of that as well. Or there could be select, subsets of enzymes. So for instance, if I'm affecting COX-1 versus COX-2, we'll get to these examples later on, so don't get too worried about memorizing these here, but just know that drugs can be selected to a point where they can actually isolate out specific subsets of receptors potentially. And sometimes drugs actually, due to their ancillary effects or even side effects potentially, we can get whole new uses for drugs. So as an example, there's minoxidil or Rogaine, most of which you know as being used to treat baldness and hair thinning and things like that. It was originally a blood pressure lowering medication. They tried it for that, realized it wasn't a very good blood pressure lowering medication, but it did cause the side effect of increased hair growth. So they said, well, let's not use it for blood pressure. Let's use it for hair growth instead, unless you can have new therapeutic uses for the drug, right? Overall, though, you're going to see that when you're selecting a drug for a particular patient, you have to consider all these factors: the selectivity, the toxicity, duration of actions, all these things. And you're going to find that it's not just as clear as looking at potency or efficacy. You got to look at all these other things as well to figure out what's going to be best for your patient. And then even getting more complicated, looking at things like cost and insurance coverage, all these different things can really play a big role there. Okay, so that's it for this first section. Of course, I go on for an extra hour more so than I intended to, but that's okay. If you have any questions, I'm going to post them up there. I'm going to move on to the next section, though, into our pharmacokinetics. Let's see. There's no questions up on the sticky board yet. That's okay. Actually, I'm going to keep that there. All right. So let's get into the topic of kinetics here. So we're going to spend the rest of today on. So absorption, when we say kinetics, we're talking about the absorption, the distribution, metabolism, and excretion of a drug, right? So ADME is what we're talking about here. And so the first thing is absorption. How do drugs get absorbed, right? How does it actually occur? And so for this to happen, we need permeation, right? We need drugs to be able to move across different membranes to get to their site of action, or to even get into the body in the first place, right? So if I'm taking a drug orally, it has to be able to get through the intestinal wall, it has to be able to get through the capillary wall in order to get into the bloodstream, right? Or if a drug works in the brain, it has to be able to cross the blood-brain barrier. How does that happen? Well, it has to do with aqueous and lipid diffusion, okay? If you remember, going back to your basic biology here, all of your cell membranes are made of this phospholipid bilayer, right? And again, that's going to have a polar and a non-polar region here that cells or drugs have to be able to cross through in order to get to its potential site of action, right? And so basically what we're going to find here is that most of the diffusion that occurs is just due to passive diffusion, right? Meaning that there's no energy involved with this, and things just go from a high to low concentration, just as natural, right? Most of you are familiar with this concept here. Lipid diffusion, though, and how well a drug can actually cross these membranes is going to be a little more complicated, because a lot of it has to do with how polar or non-polar the drug is and how lipophilic it is, right? How much it likes lipids and is able to go through lipids. And so because of that, a lot of it has to do with things like the charge of the drug and also the pH of the solution as well. So for instance, you can find some drugs have an easier time being absorbed in acidic solutions like the stomach, and some drugs have a better time being absorbed in more basic solutions like, say, in the small intestine. And all that has to do with how well drugs get absorbed, okay? I'll go over some more details of that later on. Now, some drugs don't get absorbed through that means, right? So sometimes they have to have some extra help here. And so this is where we have carrier-mediated diffusion, right? These are things that are used for drugs that can't go through just by passive diffusion itself. So for example, here's a carrier that is using ATP, so it's an active process, to move a drug from one side to the other, as opposed to just passive diffusion where it can just go straight through on its own there, right? Sometimes you can have things like aqueous channels or pores that drugs can go through as well, but I want to focus on the active diffusion here, or active absorption, because of the fact that this can actually go against the concentration gradient. So I can move things from an area of low concentration, and because I'm using energy, move it to an area of high concentration, right? You can kind of go in either direction depending on how that transporter is working. And this can be really useful to either prevent a drug from being absorbed or to help it get absorbed a little more easily. Now, when I say with aqueous diffusion, you're going to find that this occurs within some of the larger compartments of the body. And so this is going to be important when we talk about things like absorption from the GI tract, right? Because the GI tract, it's not just one long, smooth tube. There's a lot of those microvilli and has a huge amount of surface area. But it can also have to do with things like the blood-brain barrier and things like that. But basically, that permeation is going to be governed by what we call Fick's law. Now, this is not something we're going to be calculating necessarily, but I want you to be able to recognize the variables and what effects that's going to have on the overall absorption or flux in this case here. And so you can refer back to this, but think about these different variables and how they're going to be affecting how much flux or how much absorption of the drug we're going to have here. So I think it makes a little more sense when we're talking about it in terms of the picture here. So there's a few different things I want you to look at, one of which is going to be the concentration gradient, okay? So what's the difference between the concentration on the outside of the membrane to the inside? The higher the difference is here, the more flux you're going to have, the more absorption you're going to have there, okay? Other things that can affect this as well is the surface area that you're dealing with. So a larger surface area allows for more absorption to occur, which makes pretty good sense. The more drug that's in contact with a cell surface, the more likely it is to be absorbed. So the bigger the surface area, more absorption you're going to have there, right? And then the thickness of the membrane also matters as well. So most of your mucous membranes are relatively thin unless drugs have an easy time crossing over, as compared to, say, for instance, if I give a drug topically or on the skin, it's a lot thicker and it's going to have a harder time. Some drugs can't be absorbed topically at all because they just can't get across those thick membranes there, okay? And then the other thing, too, to consider is going to be the lipophilicity of the drug, or how well it's going to be able to cross those lipid membranes and actually be absorbed in the first place. So going back to that equation here, you can see how all these have an effect here. So the bigger the concentration gradient, the more surface area you're dealing with, and the more permeable the drug is, or more lipophilic it is, the more flux you have, more absorption occurs. The more thickness you have in the membrane there, the less flux happens. So if I'm dealing with something like giving a drug to, say, for instance, the skin, it's relatively much more thick than you would see if I was to, say, give it a drug rectally, for instance. Relatively thin membranes there. So all those have a role to play in how well drugs get absorbed across these membranes here. And so again, you can kind of refer back to this as comparing how well drugs get absorbed in different areas of the body, right? So looking at things with high surface area versus low surface area, looking at things with thick versus thin membranes, you can see how those changes can occur. And this is some ways that the body helps to regulate how much drug is getting absorbed to reach what we call steady state. We'll talk about steady state in just a little bit. So as I mentioned, you're going to see with lipid diffusion that a lot of it has to do with changes in pH. And changes in pH can actually change the ionization state of a drug. And when I say that, basically I'm just trying to say is, does the drug have a positive charge on it or not, right? Or maybe a negative charge. Does it have some kind of charge? That charge is important because you know that things that are charged are typically more water soluble, they're more polar, but they're not very lipid soluble, comparatively speaking. So what you're going to find is that things that are charged are more lipid insoluble, but they're more likely to go into aqueous solutions. Uncharged drugs, though, have an easier time being absorbed there. And a lot of this has to do with, and some of you might have some PTSD from this, but talking about the Henderson-Hasselbalch equation and going back and talking about your ionization state of the drug, as looking at the pKa of the drug and then the pH of the solution. You're definitely not going to have to be able to calculate this, but what I want you to know is be able to understand that if I put a weak acid, a weakly acidic drug, into an acidic solution, what does that mean for its ability to be absorbed across these membranes here? So we're going to get into that right now. So looking at weak bases and weak acids here, you're going to see here that when a weak acid by itself, when it's unprotonated, is in a negatively charged state, right? This is going to be more water soluble but less lipid soluble. If you put it into a solution where it has a lot of extra protons floating around, and protons are just hydrogen ions, it's going to be able to bind with that acid, and it puts it into a uncharged state. It's now protonated, picked up a proton, but it's uncharged. This increases the lipophilicity and allows it to be absorbed more easily across the membranes. On the flip side, though, weak bases are a little different. Weak bases by themselves are actually uncharged when they're unprotonated, right? If they go into, say, a very highly protonated solution, we're going to talk about what kind of solutions those are in a moment, it's going to be able to pick up a proton, and now it's in a charged state. Now it does not like to go across membranes quite so easily, right? And you're like, what the heck does this even mean? What are you talking about? Well, it's easier if you look at it in terms of a pictorial example here, in terms of lipid diffusion and how easily things can cross over. So let's say we're in the GI tract, and we're looking at how well a drug is getting absorbed across these microvilli to eventually be absorbed into the body. Well, if I have an acid that is a weakly acidic drug that's in this charged state, let's say, for instance, I'm putting it into, and again, when I'm talking about how many protons are floating around in a solution, that directly has to do with the pH. The higher the hydrogen ion concentration, the more acidic the solution is, right? So again, the pH will be lower, the solution. The pH will be lower. If I start to reduce the hydrogen ion concentration, the higher the pH is going to be, the more basic the solution is, right? I know we're talking about basic solutions, even though it's a complex topic, right? But point being is that you can see that the pH can actually change quite drastically depending on where you're at in, for instance, the GI tract. So if you're looking at the pH, say, of the stomach, it's like 2 most of the time. So very acidic, a lot of protons floating around because your body's producing the stomach acid, as opposed to when it gets into the small intestine, where the pancreas is releasing things like bicarb and things like that to try to neutralize all those contents. You're going to find the pH is much higher, closer to neutral. And that's going to have a really big effect on the ionization state of these drugs and how well they get absorbed. So what happens here is if I put a weakly acidic drug into a more acidic solution, you're going to see it's going to pick up a lot of these protons here. It's going to be in an uncharged state, right? Notice here the negative has been counteracted by this positive here and is now neutral. This means that it's protonated, it's neutral, it's kind of an easy time crossing of this membrane here, right? And then depending on how this change occurs here between one side to the other, pH can be different here. It can then cause the same thing to happen. If the weakly acidic drug is in the unprotonated state here, it's charged, negatively charged, it's going to bounce right off that membrane. It's going to have a harder time being absorbed here, okay? On the flip side, if you're looking at a weakly basic drug, you're going to find that in its uncharged, unprotonated state here, it has an easy time being absorbed. So this would be in a more basic solution where there's not as many hydrogen ions around. It has an easy time being absorbed, versus if it picks up that proton, it's going to have a charge on it, and it's going to bounce right off that membrane. So again, this has a really important role to play in terms of absorption from the GI tract, but also it has a role to play in other cases too, because sometimes you can actually find that depending on the difference in pH between these two sides here, you can actually trap drugs in certain body compartments, right? So for instance, if you were to have a pregnant woman who is or not pregnant, I guess she's not pregnant anymore. If a woman who is breastfeeding, right, a new infant, you can actually have drugs that will concentrate in the breast milk, because the blood is 1 pH, about 7.4 or so, versus the pH of the breast milk, which can be a different pH, it's a little more acidic. So what you can find is that by changing that, you can actually trap a drug, right? So for instance, if I were to have, say, a base that was over here, a weakly basic drug in the bloodstream, and it's, in a state where it can be absorbed because it's in this uncharged state, it can cross right over. But then if it's in a more acidic solution, it's going to pick up a hydrogen ion, and now it's trapped here. Now it's going to bounce right off that membrane. And what does that mean for the baby? Well, it means that they're now exposed to more drug because it's concentrating in the breast milk, right? So again, this does have real-world application, not only just in drug absorption, the GI tract, but also drug exposure to things like, an infant, for instance. So, and basically this is what the Henderson-Hasselbalch equation is. Don't calculate this by any means unless you just are looking for some fun. But what this is doing is telling us this ratio here between the non-protonated versus the protonated species here, right? So again, how are you shifting that towards favoring one versus the other will have an effect on how much absorption you have here, right? So the more protonated a weak acid is, the easier time it's going to be absorbed. The more protonated a weak base is, the harder time it's going to have being absorbed, and vice versa, okay? And again, when you're looking at a drug's pKa, which is every drug has a pKa associated with it, if you were to put a pKa a drug in a solution where the pH is equal to the pKa, this actually means there's going to be a 50-50 split between protonated and non-protonated species here. You can see this is going to be equal. But if I were to shift this either direction, you can see I will favor one variety over the other, right? So for instance, if I were to put a drug, a weak base, into a solution that gets more and more acidic, you're going to notice here that I'm going to be predominantly forming this charged form of it. I'm going to have a harder time being absorbed, versus on the flip side, if I were to put that weak base into a more basic solution, I'm going to have this predominant form of the uncharged, non-protonated state. It's kind of an easy time being absorbed, okay? And again, I can do things to modify this, right? I can give medications that cause drug interactions to cause issues here, right? So for instance, if I have a weakly acidic drug and I were to say change the pH of the stomach, that can affect absorption, right? So how can I do that? Well, have you ever heard of an antacid like Tums, which is just calcium carbonate? Calcium carbonate is meant to neutralize stomach acids. So if I were to do that and raise the pH of the stomach from say 2 up to say something closer to neutral, closer to 7, I can then cause more of the drug, of a weakly acidic drug, to be in the charged state and can decrease absorption, right? Just one example, and I'll give you some specific ones when we get to them. But that's why a lot of antacid drugs can cause a lot of drug interactions, because they actually prevent things from being absorbed, right? So just to give you an example here, so let's say we're in an acidic solution, say we're in the stomach, again, where it's a pH of 2. Looking at something like aspirin, which is a weak aspirin. If you've ever seen aspirin abbreviated, it's ASA. That stands for acetyl salicylic acid. So aspirin's a weak acid. You would find that in the stomach, it would be protonated, thus it's more lipid soluble. It's going to have an easy time being absorbed. Versus something like morphine, which is actually a weak base, it gets protonated, it's going to bounce off those membranes and have a harder time being absorbed there, okay? Again, it's not zero. There's always an equilibrium between the ratio of protonated to non-protonated species. It just depends on the pH of the solution and then the pKa of the drug itself, okay? And again, this is not a table I want you to memorize, but just know that every drug is going to have a pKa associated with it, whether it's a weak acid or a weak base. And I just want to give you some examples of different ones that are out there, okay? So what are some other ways that we can find drugs to be absorbed here? So we can have special carriers, right? So this is good for substances that can't really get across any other way. So for instance, we have things like amino acid carriers in the blood-brain barrier. Normally, amino acids would be able to cross over on its own. Sometimes drugs can utilize these as well. Or for instance, you have things like weak acid carriers in the renal tubules that allow for either absorption or excretion of substances there. But these are special carriers that are used. And these are useful for things that can't cross the membranes on their own. And when you're using carriers like this, instead of just passive diffusion, where changes in concentration gradient will have a big effect on how much is being absorbed, these are not going to be under the same rules as fixed law, because they're capacity limited. What I mean by that, there's only so many transporters, and once they're occupied and they're saturated, then you can't give any, or you can't speed that process up at all, right? So even if I keep giving more and more drug, it's not going to increase the speed of absorption anymore once you saturate these transporters here. So frequently, they also require energy. So if there's no ATP around, they're not really going to work all that well. They can also go against the concentration gradient. So this is very different than what we saw with fixed law, which was just passive diffusion through a membrane, right? Sometimes we can actually even have transporters that try to prevent things from being absorbed. We have transporters that are trying to spit drugs back out and try to get rid of them. And so this is really helpful as a protective mechanism. So for instance, like the blood-brain barrier is very selective when it allows to cross over, right? Which is good, because your brain is pretty important, as it turns out, and you want to protect it from poisons and toxins and all kinds of things like that. And so here's an example of one. We call this the multi-drug resistance transporter, or MDR1. There's a lot of different varieties of these, but also another name for this is called P-glycoprotein. This is important because you find it in the brain. It's basically it's called an efflux pump, meaning that if something were to cross the membrane, this pump can then activate and kick it back out, essentially, right? So it's kind of like the bouncer at a club or something like that, right? So it's saying, say someone walks into the club, but they're not wearing a mask, right? And this protein can then kick it back out, okay? So this is useful because it helps to keep things out of the blood-brain barrier. This also can do things like expel drugs back out into the GI tract. Very, very important. But you can also find that if these are not working appropriately, you can actually find there can be some issues, right? So for instance, if you've ever heard of some drugs not being able to be taken along with grapefruit juice, you're like, well, It's grapefruit juice. I mean, why would that cause any issues with drugs? A lot of it has to do, in part, to do with this special transporters. So if I were to have a patient on a statin, which is a type of drug used for, it's a class of drugs used for hyperlipidemia, some of these drugs go through and are effluxed by this drug, this P-glycoprotein, and grapefruit juice can inhibit that, right? So if this is not working as well and it's not expelling the statins back out into the GI tract, and basically what you're going to find is those levels of statins are going to go up because I'm not expelling as much anymore. And that sounds like a good thing because you're like, okay, more drug is good. Not necessarily, right? You can have too much of a good thing, and this can actually lead to liver damage and rhabdomyolysis, muscle breakdown. So there can be some issues along with this. And so just to give you some examples of where PGP is working, imagine you have the small intestine here, the intestinal lumen. Here's the bloodstream. Drugs have to be absorbed through into these enterocytes, but then I can have things like different transporters like PGP spit it back out. Okay, if I block this, I prevent it from working, that allows more drug to be absorbed, which potentially can lead to toxicity, right? Or here's some examples of some hepatocytes actually utilizing different efflux transporters to actually spit things out into the bile. And so this is going to be one way we can actually get rid of drugs, is not just through the kidneys, but also get rid of it through the biliary tract as well. So this is a really important concept. We'll talk more about these as we get into the specific drug classes later on. Some other means of drugs to get absorbed. So there's endocytosis, which most of you are probably familiar with this concept. If a substance is, say, too large, or maybe it's not lipid soluble, or otherwise cannot get across a membrane, this is a process where basically the cell can engulf the molecule, can put it into a vesicle, and then can do whatever else it needs to do with it, right? So for instance, things like iron, with transferrin, this is a process of endocytosis and how you would actually get iron absorption. B12 with intrinsic factor, things like that are all useful for helping the drugs that otherwise would not get absorbed to get into the system. And we also have the opposite, which is exocytosis. So this would be in the case here where you're expelling the drug through these vesicles. And this is actually really important in terms of things like neurotransmitters and hormones and insulin and calcium, all these different things. Basically, these vesicles can fuse with the cell membrane and allow for the contents to be expelled out. So this is really important for like how the pancreas works in terms of endocrine function and things like that. So obviously you can see here exocytosis where the vesicle fuses with the membrane and allows for things to be expelled, versus here with endocytosis, things are being engulfed into a vesicle that pinches off from the cell membrane and thus can go and do whatever it does, right? So that's how things get absorbed. Now, once it's in the system, where does it go, right? Does it like to stay in the bloodstream? Does it like to distribute out into the fat and the muscle? Like where the heck do these drugs go? And this is where we talk about distribution, right? And so there's a concept called volume of distribution, and this is always a sticking point for students. Perhaps I have never developed a good way to teach this to people, or it's just an inherently complicated topic. We'll never know, but if you come up with some tips, let me know. But anyway, so volume distribution is sort of a theoretical number, but it gives us an idea of where do drugs like to go to in the body, right? And so there's two main compartments I'm going to talk about here. It certainly gets more complicated, but again, I'm trying to make this applicable to you all as PAs. Does a drug like to stay in the bloodstream, in the central circulation, or does it like to distribute out into the tissues? And if it does, how much of it likes to go out there, right? And so you can see that some drugs really love to hang out in the fat. Some drugs don't like to do that. They like to hang out in more aqueous compartments like the central circulation, like your blood. So I always like to use marijuana as a good example of this. So if you've ever seen marijuana being used for, not for smoking necessarily, but for like cooking purposes, right? Marijuana itself, and the main active component we're talking about is THC. THC is actually quite lipophilic. So that's why you oftentimes will see it in different type of like baking products, or you'll see it THC being used in like oils and things like that, because it loves fat. Very lipophilic, right? And so THC is used in a lot of those cooking products. Well, where does THC then like to go in the body, say if you were to consume that marijuana or consume that THC? Well, it still likes fat, right? So you can actually find that patients will have a buildup of THC out in the adipose tissue. And that's the reason why some patients can stay positive on a urine drug screen for sometimes weeks to months after they've last used marijuana, because it just likes to hang out in the fat. It just likes to distribute out there. Okay, and so volume distribution is going to help us to determine, well, does it like to go into the fat, does it like to go out into these tissues, or does it like to stay within the blood supply? And so when I say central circulation, that's what I'm talking about, is the blood supply. Okay, So volume distribution is basically how we would calculate this is to determine how much drug we're putting into the system, and then we can actually measure the blood, measure the plasma to determine the concentration. Okay, so looking at this, if I were to say give you a drug that likes to stay in the bloodstream, I should probably be able to find a lot of that drug there when I do a concentration in the plasma. If I actually measure that, most of it's going to still be there in the blood, and I can measure that. But if I notice that the concentration is really low, I already know how much drug I gave you. So if the concentration is low, that means that, well, the drug went somewhere. It probably distributed out into the tissues. And so if I were to do a tissue concentration, which really you can't do clinically, it would actually be a high concentration. But when I measure it in the blood, because all of it distributed away, there's not a whole lot there, right? And so there's a couple concepts here I'm going to have you look at. I'm not going to have you calculate this specifically, but I want you to know these concepts here in terms of how to actually to know how this can affect the volume distribution, know how the concentration can be affected here. Because if you recall, we were talking about narrow therapeutic index drugs. This can have a really big effect on that, right? Because I'm looking to make sure I'm staying within that narrow window to where the drug is effective, but the levels aren't so high that I cause toxicity, right? So let's look at how this actually works. So volume distribution, if I look at this, I can calculate it by looking at the total dose of the drug that I give a patient, and then I can look at the concentration that is resultant in the plasma. So if I were to say give 25 milligrams of a drug, and then I measure a level in the patient's blood, and I get 5 milligrams per liter, I could then divide that out and figure out that the blood volume distribution for that drug is 5 liters, okay? Okay, well, what does that really tell me? Well, based on that, I can figure out, okay, well, is that a large volume of distribution or small volume of distribution? Things with large volumes of distribution like to go out far into the tissues. They like to hang out in the fat and the muscle, all these different places, versus things that have a low volume of distribution like to stay there in the bloodstream. Okay, I can tell you this would be a relatively low volume of distribution, but sometimes you'll calculate it and you'll get levels like volumes of distribution like 200 liters, and you're like, well, a patient doesn't have 200 liters of anything in the body, so the numbers doesn't necessarily have to make sense from a physiologic standpoint, but it's basically telling us, again, does a drug like to go out into the tissues or does it like to stay in the bloodstream? And that can be really important because where is the drug working at? If a drug is, say, working in the lungs to treat an infection, I'm giving the drug intravenously, that drug has to get to the lungs in order to work. You can't just hang out in the bloodstream. And so this can have a really big implications in terms of being able to actually treat a patient's disease state by actually getting the drug to where it's supposed to work, okay? Generally speaking, though, drugs with high volume of distribution, like I mentioned with THC, tend to be lipophilic, right? And they distribute extensively throughout the body. And that's going to have a lot of effects on things like clearance in a little bit, as we'll talk about in a few slides here. But let's look at another example here. So looking at two different drugs. Let's say I have drug A, which is hydrophilic, and I have drug B, which is lipophilic, right? So drug A being hydrophilic, it likes to stay in water, and that means it's probably going to want to stay in the central circulation or in the blood, okay? Drug B, which is lipophilic, likes to go out to the tissues. So if I were to have two identical people, and I were to give one of them drug A and one of them drug B, and I give them the same exact dose, I'm giving them 50 milligrams of drugs to these two different individuals that are exactly identical in every way. What I could actually do is and then measure the resultant concentration I get in the plasma, and I can then compare the two together. So what happens? Well, if I were to do that, drug A, which is hydrophilic, I mentioned, only has a volume distribution of about 5 liters or so, right? Versus drug B has a concentration of only 0.5 milligrams per liter, right? I gave the same dose of drug, but if you notice here, the levels are wildly different, right? Does that mean that the drug disappeared? Well, no, I just can't measure it out in the tissues, but it's still there. It's just distributed out. So then if I were to measure that, then it turns out to be 100 liters. And again, the patient probably doesn't have 100 liters of anything for that drug to really go into, but it's a theoretical number, right? It tells me how much that drug likes to go out into the tissues versus staying there in the bloodstream. And you can see this here. You can actually look at a variety of different drugs, and you can see some have very low volumes of distribution, things like insulin and heparin, which we'll talk about all these different drugs later on, versus drugs that have much higher volumes of distribution. So things like chloroquine or its cousin hydroxychloroquine, which you may have heard about if you've paid attention to the news, has a very high volume of distribution. It loves to go out into the tissues, right? Versus something like heparin has a very low volume of distribution. Heparin, which is used as an anticoagulant, likes to stay in the bloodstream, which makes sense because that's where the drug works, right, to prevent clots from occurring. Ultimately, what you're going to see here is that when you're looking at a volume of distribution for a drug, it's usually expressed in liters per kilogram, which you can then multiply by your patient's weight to determine what their particular volume of distribution is. But looking at this, you can see that that the cutoff point between something that's a low versus a high volume of distribution is 1 liter per kilogram. Okay, that's a handy number to remember. So 1 liter per kilogram. If it's higher than that, it's a high volume distribution drug. If it's lower than that, it's a low volume distribution drug. Okay. So, that's all well and good, but also, volume distribution can change, right? So why or what are some things that can cause that to change here? Well, you can see that volume distribution can be decreased, and some of this depends on whether the drug is lipophilic or hydrophilic, but typically you're going to find that plasma protein binding, right? What does that mean? Well, basically, if I have more proteins floating around in the plasma, things like albumin, and I have more of that being bound to the drug, right? The drug's binding to a lot of those plasma proteins. They're being sequestered there in the bloodstream. That lowers the volume of distribution because maybe it wants to go into the tissues, but all that albumin is holding onto it, preventing it from distributing. That raises the concentration of the blood because it's all being sequestered there, and thus that lowers the volume of distribution. Also, what if you have something like dehydration, right? So you have a hydrophilic drug, something that likes water, but you don't have a lot of water in the system because the patient's been vomiting, or they have severe diarrhea, or they just have really poor water intake. That can then concentrate the blood and also concentrates the drug, so that lowers the volume of distribution, right? Although we can also see the flip side where volume distribution can be increased, right? So not only can you have tissue proteins that can hold on to the drug and keep it out into the tissues, but you can also find things that increase the amount of body water that is available, right? So if you have someone who has renal failure and they have a lot of fluid retention, they have a lot of edema, drugs can distribute into that, and that causes the volume of distribution to increase because I can't measure it in the blood anymore. Or if I have liver failure and the patient has ascites, all that can cause big changes and cause volume distribution to increase in those cases. So there's that. Let me get into metabolism here. So now we've seen how the drug gets absorbed. We've also seen how it gets distributed throughout the body. But now we got to figure out, how do we get rid of it, right? Because drugs don't stick around in the system forever, ideally. So we've got to get rid of them at some point, right? You don't want drugs to stick around forever because they can lead to some issues. So metabolism. How do we actually metabolize drugs? And so basically what is happening here is that this is where we're either one, terminating the function of the drug such that it is losing activity, or altering something about it such that it now is ready for elimination from the body, right? So typically what you're going to find is a lot of these metabolic reactions are going to try to cause the molecule to be more hydrophilic. The more water soluble these substances are, the more likely they are to be eliminated through the kidney. And that's the last thing we'll talk about here in just a few moments. And again, these metabolic reactions are typically deactivating, right? They're trying to eliminate the function of the drug in order to get it ready for elimination. That's not always the case. In some cases, we'll find drugs actually have active metabolites that do the same thing as the parent compound. But in general, you're going to find that the metabolism here is going to deactivate it and then get it ready for elimination from the kidneys or the biliary tract, wherever it gets eliminated from. Okay, generally want to be more polar, so it's more likely to be filtered by the kidneys. So what's actually interesting, though, is sometimes we give drugs that are inactive. Why would you ever give an inactive drug? Well, sometimes it's what we call a prodrug, which is actually given in the inactive state, but we rely on the body to metabolize it into the active form. And where does most metabolism occur? Well, it's going to be in the liver. So we're going to focus a lot on the liver here, as we'll see in just a few moments. So looking at a few examples of prodrugs. So we have things like ACE inhibitors, which are really common antihypertensives. If I were to give this orally as a drug enalapril, it's then going to be absorbed and go through the liver where it gets metabolized into enalaprilat. That's the active form. That's what actually lowers blood pressure. Or codeine, as I mentioned. Codeine is not a very good analgesic, but once it gets converted into morphine, now it's functional. Right now it can actually cause pain to decrease. Or here's another example of an ADHD drug called lisdexamfetamine, or Vyvanse is the brand name here. This is inactive when taken orally, but then when processed and metabolized through the liver, turns into dextroamphetamine, and then now you're able to study more, have better focus, things like that. So metabolism mainly occurs in the liver, but it can also occur elsewhere. You can find things like the GI tract, kidneys, lungs, things like that, but we're mainly going to focus on the liver here. And again, the goal is to deactivate the drug and get it ready for excretion, generally by making it more water soluble. Okay, there's gonna be a couple ways that we can do that, and there's gonna be two main phases of metabolism: phase 1 and phase 2. Some drugs only go through phase 1, some drugs only go through phase 2, some drugs will go through both. Okay, we'll talk about these in more detail. But phase 1 reactions, this is where basically we're modifying the shape of the drug or the composition of the drug in order to make it more polar, right? You're modifying the substance. You're not adding anything to it. Phase 2, we're going to see is where you add stuff to the drug. But mainly this is where we're going to run into things like oxidations and hydrolysis and reductions. The main one we're going to focus on here is going to be oxidation, okay? So the main thing we'll talk about is, there's a lot of different different phase 1 enzyme systems here. So you see like esterases and amidase and all of that. I really want to focus on this oxidative pathway performed by cytochrome P450. If you've ever heard of CYP P450 before, it's probably heard about it in relation to things like drug interactions and things like that. This is a super important. If you take away anything from this metabolism section, it's know about cytochrome P450 because it is the most important drug metabolizing system that we have. And so then moving, I'll talk more about that in detail in just a moment. But phase 2 reactions where you actually add onto the molecule something to make it more water soluble. So we can conjugate it with different functional groups. We can add glucuronide groups. We can sulfate it. All these things make it more water soluble and able to be eliminated through the kidneys most likely. So this is an example. And again, I'm not trying to freak anyone out with the medicinal chemistry by any means, but I want to illustrate how drugs can go through different metabolic pathways here, right? So here's acetaminophen, Tylenol, most of you know. And so you can see here how it can go through both phase 1 and phase 2 reactions depending on the circumstances. So what you can see here is that we have maybe 2/3 of the drug normally going through glucuronidation, which is a phase 2 reaction because I've added on a glucuronide group. And then you can see about 1/3 of it normally goes through the sulfation pathway where I add a sulfate group onto this. These are phase 2 reactions that can lead the drug to be more water soluble and ready for elimination through the kidneys, right? Although a small portion of it will actually go through CYP P450 and specifically the 2E1 enzyme. And so this is a phase 1 reaction. Right now we're modifying the molecule, and this is actually where we can end up getting kind of a nasty intermediary product called NAPKI. But the important thing is that it then goes through phase 1 and then phase 2 reaction where it actually gets glutathione conjugated and then eliminated through the kidneys, right? Small percentage of it does that. Don't memorize this. The main point I'm illustrating is that the drugs can go through phase 2 reactions and go through phase 1, then phase 2, sometimes just phase 1. It just depends on the drug, right? So don't get too hung up on that. Just know that drugs can go through all these different processes here. And so just give you an example of a few different types of systems here. I'm mainly going to focus on the P450 here in just a moment, though. But just know there's different ones that are out there used for different functions. Different drugs go through different ones potentially, or sometimes multiples, right? So an important thing to consider too is, and I think I mentioned this last week, but we talk about what we call first pass metabolism. And this is mainly to do with oral absorption of medication. So if I give a drug orally, the first place it's going to go to once it gets absorbed through the intestinal membranes is actually to the liver, right? It's going to go through the portal system to get to the liver, and some degree of that drug may be metabolized, right? So you've not gotten any effect out of this drug whatsoever, but before you can have that effect by having it pass through to the systemic circulation, the liver is going to take its tax, right? Some drugs have no tax taken. Some drugs have all the tax taken, and thus you can't even give them orally. So what I call this is the first pass effect. And it can vary on the medication. As I mentioned, some drugs will have a very small amount of metabolism to no metabolism in the liver as it passes through into the systemic circulation to have its clinical effect. Some drugs are extensively metabolized and thus have very little of it actually get through. Okay, the percentage of drug that gets absorbed via any of these routes is called bioavailability. So drugs that have a high first pass effect have low bioavailability, right? Now, we mentioned last time we talked about different routes of administration. Which route has the most bioavailability is guaranteed? Well, it's IV, right? Giving a drug intravenously has 100% bioavailability, whereas with oral intake, you can find that it's variable, quite variable, so 0% to 100%. Sometimes that's why you actually find that drugs may be dosed quite differently. If you look up different drugs, you can see that sometimes when given orally and then given IV, it's the same dose. It's 1-to-1. Sometimes you find that the doses are wildly different. Sometimes it's a factor of 10 sometimes. You're giving 10 times the dose orally as you would IV. A lot of it has to do with this first pass effect. So basically, the liver is metabolizing a portion of that drug before it gets passed on to the systemic circulation where it can actually cause its clinical effects there, right? So other metabolism sites can include things like gastric acid. Sometimes gastric acid can destroy a drug preventing it from being absorbed. That's why we don't take protein-based medications orally. So it'd be nice if I had a pill that contained insulin, but that doesn't work because the stomach acid will chew it up just like it does a hamburger or a steak, right? Digestive enzymes can do the same thing. The gut flora, so the natural bacteria you have in your GI tract, can have an effect on metabolism as well. So a lot of other ones here, but we're mainly going to focus on the liver here. And we can see that also like disease states have a role to play here too. So I can have patients who have an impaired hepatic function, and that actually can slow down how well they can metabolize drugs. So what does that matter? Well, if I can't metabolize a drug, it's going to stick around for longer, and thus that means I'm going to have higher levels, and that can lead to toxicity potentially, right? Here's just some examples of different things that can impair a drug from being metabolized through liver impairment, right? You also find that occasionally renal disease can have a role to play here as well, and cardiac disease additionally. So basically anything causing a lot of vascular backup and preventing blood from flowing through the liver, so things like CHF, for instance, can prevent you from presenting that drug to the liver and thus preventing it from being metabolized. So as an example here, sometimes we'll use the drug lidocaine, which most of you might know as a local anesthetic. We can give as an antiarrhythmic. It actually treats certain types of arrhythmias. I have to lower my dose extensively when I have someone with CHF because they don't process that blood through the liver as quickly, and thus they don't metabolize it as well, right? So because they're not metabolizing as well, I give less drug in order to account for that. Even things like endocrine function can have a role to play here. Your genetics can play a role. Even your diet, right? I mentioned before that like grapefruit juice can inhibit certain metabolism pathways. I can have charcoal broiled food. Say, for instance, if we ever get out of the house and have a barbecue again, you may be able to induce those enzymes, right? If I'm inducing the enzymes, meaning I'm metabolizing more quickly. If I inhibit the enzymes, I'm not metabolizing as quickly. That means levels go up, right? Inducers would cause levels to go down. We'll talk more about some examples here, but you can see there's a lot of different factors that play a role in terms of how well drugs get metabolized. Here's a reason why we have so many different drug interactions that can occur, a lot of them through this metabolism issue here. So just real brief, I want to finish this topic up before I let you guys go for the week, but I want to talk about cytochrome P450 here and why it's so important. Basically, it's involved in so many different drug interactions. It's involved in affecting how intensely we can experience drugs, how long they stick around for, by how well the system is working or not working, as the case may be. You can see that there's a lot of different types of enzymes under the umbrella of cytochrome P450, right? There's over 1,000 of them that have been identified, probably like more than 50 functionally active and just in people themselves. And we're talking about the different forms of them, the different isoenzymes. So when I talk about CYP P450-3A4, you'll know that's different than 2D6 because of these isoenzymes. We'll talk about some of the main important ones here in just a moment. But basically how I classify the different enzymes, you can see that CYP is how we're going to be abbreviating cytochrome P450. So CYP is a P450 enzyme, and then we can actually get further delineated into the family, subfamily, and individual enzyme itself. So CYP2D6 here, you can see a lot of this is based on the amino acid sequence of it. So why do we care about that? Well, because so many different drugs are metabolized through the CYP450 system here. And again, don't memorize this slide. We'll get into the specific examples. But you can see that, for instance, here, the ones that have a lot more drugs under them are probably going to be more important. But for instance, 3A4 metabolizes like 50% of the drugs you're going to be given to patients, right, are all metabolized through CYP3A4. This is the most important one we'll talk about. But look at here. You can see some of them will induce the enzyme, meaning they'll upregulate the amount of enzyme available, thus causing you to metabolize drugs more quickly, thus dropping the levels. In some cases, you'll have inhibitors that actually slow down the metabolism, causing levels of these drugs here, the substrates, to go up. They can lead to toxicity. Sometimes we do this on purpose because it actually helps to boost levels of the drug to make it more effective. It's a rare case, but sometimes we do that. So, and if you can look here to look at the different isoenzymes, you can see here that the lion's share of metabolism is going to be occurring through CYP3A4. So this is a super important one. If you take away nothing else from this metabolism section here, it's to know that CYP3A4 is extremely important in terms of metabolizing drugs. About 50% of drugs you give will go through CYP3A4, and you're going to find this is a source for a ton of drug interactions, right? Why do we care about drug interactions? Because it's a good way to either harm your patient or kill them in some cases, right? So you got to be really careful with this stuff. Here you can see some of the phase 2 reactions that happen there. Again, it's a little bit more of a mixed bag, but really I'm obviously harping a lot on the CYP3A4 and the CYP system in general, so it's probably a good idea you want to know something about that, right? Okay, so that's it for this section. Well, what I'm going to cover today. We'll get to the rest of this next week, along with our week 3 content. I'm hoping to catch back up, but that first one is quite a bit of material there. Let me see if there's any questions on sticky board here. So I do have one question. It says, if you give a patient something like Tums, will it increase the absorption of something basic like morphine? It's a really good question. The answer is yes, it would actually. So if I have a weekly basic drug, a weak base, and I were to increase the pH of a solution that's dissolved in, that would then cause it to be more in the unprotonated, the uncharged state, and that would actually enhance the absorption, right? Clinically, does that come up often? Maybe not. It depends on the patient there, but it may be something you educate on, right? So you may say, for instance, to patients, say you're dealing with like a weak acid like aspirin, you say, hey, don't take this along with Tums, or maybe separate them out, because that can affect how well the drug gets absorbed potentially. So yes, that is absolutely the case there. That's what would happen. Okay. See, when is the mandatory tutoring session this week? I would reach out to Dr. Kaufman in order to get that. That's dependent on your schedule. I don't have a lot of sway over that. So I would check with them about the schedule from that standpoint. Unfortunately, with me being distant and being an adjunct, I don't have a lot of control over that. But I do know that's supposed to be happening. Let's see. Any other questions from you guys? Nothing in the chat. You guys are kind of quiet. So either I bored you to tears already, or I'm explaining everything really well and you have no questions. Don't know how true either one of those statements are. But otherwise, make sure you take that quiz on this week. You can take it multiple times. It'll give you some ideas about sort of the concepts you should be starting to understand, some of the definitions, as well as giving you an idea of how I write some of my test questions. Again, this early quiz is not covering like specific drug topics, so you don't really know how those questions are going to go. We'll get to them though. Let's see. Brooke is asking, is the remaining info we didn't cover in today's PowerPoint on the quiz? I don't think anything is on the quiz. I think it's mainly just on week 1, so it won't be there. And again, the quiz is more of a participation thing. You can take it as many times as you want to get a perfect score if you like. It's really just more for your benefit. Yeah, it will take the highest score, so I set that up. So no issues there from that standpoint. Again, take as long as you want on it. Take it multiple times. I don't really care. It's really just to give you, get you prepared a little bit for the type of questions you might see in the future. Is it due Sunday? I believe, yeah, it's, actually, I don't know if I put a due date on it, but yeah, you need to have it done by Sunday. I'll correct that. So I'll do Sunday at midnight. I guess that will 11:59 p.m. to be specific. So make sure you get that done. If you have any questions that come up about it, just let me know. Otherwise, you guys are free to go, and I will see you all next week. I'll hang out here for a few more minutes in case any questions pop up. But you guys have a great week. And yeah, email me if you have anything, or put it on the sticky board for next week, whatever you like. Everyone's sticking around maybe to see if any other questions come up. But we'll go ahead and stop the recording. All right, doesn't look like anything's popping up, so I will go ahead and cut it off. Thanks for joining me. I will see you all next week.